Good afternoon and good evening, everyone, and welcome to the third session on patient safety and quality improvement for this the first ever World Sepsis Congress. My name is Kevin Rooney, and I will be your chair for this session. I'm an anaesthetist and intensivist and professor of care improvement in Scotland and the United Kingdom. So I'm really looking forward to this session, which, if it's as informative as the one I was involved in this morning, will be fantastic. We've got 5 excellent speakers lined up, and we've also got a video as well, so we'll have a really truly exciting session. So I'd like to first introduce our first speaker, Dr. Unal from Turkey, and he's going to talk about the Turkish approach to sepsis awareness and education. Dr. Unal is a professor of anesthesiology and reanimation at Ankara University. He is a past president of the Turkish Society of Intensive Care and is coordinating the World Sepsis Day activities in Turkey. He's also a very strong experience in intensive care medicine with an emphasis on mechanical ventilation and sepsis. So I'm now going to pass you over to Dr. Unal, and if you take us away.
Good morning, good afternoon, and good evenings for everybody joining to this session from all over the world. It's really a big pleasure for me to be invited to such a big and excellent organization. My speech will be concentrated on national data and activities. Initially, I would like to give you some information about Turkish healthcare system. We have acceptable number of medical doctors in Turkey. On the other hand, there is a very severe shortcoming in number of nurses, especially in intensive care. There are about 32,000 intensive care beds in Turkey. The ratio of ICU beds to inhabitants and to total hospital beds are better than several European countries. However, health expenditures of Turkey is lowest of all OECD countries. In a study published 2 years ago, it has been shown that outpatient antibiotic usage in Turkey is higher than all Central Asian and some Eastern European countries. It was mainly related with antibiotic sale and usage without prescription. However, this situation was ended by a directive issued a few years ago. According to the report of World Economic Forum published in 2015, the daily amount of antibiotics used in Turkey is higher than the European countries, and even it's nearly twice the level of some countries. Antibiotic consumption of our country within 10 years period between 2000 and 2010 has increased approximately by 85%. This increase is higher than other countries except African countries. As a result, antimicrobial resistance rates for different groups of antibiotics are high according to national surveillance reports on nosocomial infection published in 2014. Under the light of available data, a sepsis working group were created by Turkish Society of Intensive Care in 2014 with the collaboration of GSA and Turkish Ministry of Health. This group initially translated sepsis guidelines and bundles to Turkish, prepared some posters, booklets, and some educational sets for awareness, diagnosis, and treatment of sepsis. Then we trained about 250 trainers from 54 cities of Turkey on web meetings for upcoming educational campaigns. Our first campaign, Sepsis Awareness Education Campaign for Healthcare Professionals, launched by previous Minister of Health, Dr. Mezinoğlu, during World Sepsis Day in 2014 in Istanbul. About 23,000 healthcare professionals working in 71 cities of the country have received this training in a period of less than 4 months. During this period, GSA World Sepsis Day film was broadcasted on various websites, including TSIC and Ministry of Health websites. Some television programs were also organized during this period. Opening session of 20th International Symposium of our society organized as a joint meeting with Global Sepsis Alliance. A ceremony was held after the joint meeting to award the Turkish Ministry of Health for their contribution to national sepsis campaigns by GSA. We think that these kind of awards are so important to increase the awareness and also to get more support. Press meetings organized during symposium has found place in 54 press reports, 2 TV news, and more than 200 web pages. Just before the World Sepsis Day in 2015, press meetings were organized in 10 cities of Turkey simultaneously. Press meetings have been subjected to at least 20 TV news on very well-known 9 national TV channels, more than 160 newspaper reports, which have approximate circulation of 2 million, in addition to more than 1,000 online news. Turkish was the most commonly used second language during World Sepsis Day webinar in 2015. I believe that this is an important indicator which shows us the increasing sepsis awareness and interest among Turkish doctors. Simultaneous small meetings were organized in different hospitals during the World Sepsis Day webinar to increase webinar participation. Second big educational campaign for diagnosis of sepsis organized in 75 cities of Turkey with the contribution of around 350 instructors. About 12,000 medical doctors from more than 300 hospitals have participated to this meeting, which constitute approximately 10% of all Turkish medical doctors. Additionally, special panels for sepsis were organized during several congress and symposium of different societies. We are greatly grateful for their contribution. Another GSA-TSIC joint meeting was held during National Congress or TSIC in April 2016. In addition to this joint meeting, we initiated a new formation during this Congress. International Transplantation Network, Global Sepsis Alliance, and our society's joint meetings. Around 114 participants from 48 different countries, in addition to Turkish participants, were attended to these joint meetings. The spectrum of the countries and nature of the participants were very important for the introduction of GSA and its activities, in addition, reviewing current status of burden of sepsis with them. We know that sepsis awareness is very low in general in the world, but we had no data about Turkey. Therefore, a survey was planned and conducted by medical students of Ankara Medical School under the control of our society in Ankara. You can see those hardworking and productive young medical students on photograph. More than 1,600 subjects were included to survey. Only 11% of subjects were aware about sepsis term in spite of our activities. The awareness was proportional with the educational level, and it was not more than 20%, even in subjects who has postgraduate education. 47% of the subjects had heard it from the healthcare institution or medical professionals, and 60% of subjects had heard it from media. These results are showing efficiency of our activities and therefore supporting our policies. Meantime, World Sepsis Day working group of our society organized a national prospective multi-centered prevalence study. All ICUs except pediatric, cardiovascular, and coronary were invited to participate in the study. All centers admitted their patients' data on 27th of January 2016. And on 10th and 13th days of the study, additional data were entered. According to the preliminary results, 129 ICUs having about 1,700 beds registered more than 1,600 patients to the study. Some patients excluded because of missed data. 57% of all patients had defined infections, mainly pneumonia. Results are already under evaluation now. I will try to inform you about some uncontrolled initial data. According to declaration of primary responsible doctors, 46% of all patients had non-septic infections, 2% of all patients were in sepsis, and 8% of patients were in septic shock. Accordingly, hospital mortality for sepsis was 68% and for septic shock was 72%. However, those results were belong to declaration of primary responsible doctors. When we control the results of the when we control the recordings, which I just received, we seen that 27 of all patients had infection without sepsis. 17% of all patients were in sepsis, and 9.5% of all patients were in septic shock. And 1 month mortality rates for patients with infection was 28%. For sepsis, it was 55%. And for septic shock, it was 70%. Those are questionable preliminary results of raw data. And more evaluation is necessary to show exact prevalence and mortality rates in addition to antimicrobial resistance patterns. However, it's very clear that sepsis and infections are important causes for increased morbidity and mortality in our intensive care as other countries. And more importantly, we need more works for education. Therefore, we should show every effort to decrease incidence and mortality of sepsis. To reach this target, we need more data and therefore more convenient classification systems. We need support of politicians, bureaucrats, and media to increase sepsis awareness globally. We should improve sepsis-related education at all levels. We need global implementation of mandatory directives. And as a result, we need not only national, but also global collaborations and organizations. Otherwise, it will be too late. Thanks a lot for your joining.
Okay, thank you, Dr. Unal, for a very enlightening presentation. And it is great to see the social movement that you have made with regards to sepsis awareness and the involvement of the governmental support back home in Turkey. I have a question from you, which has come from a Dr. Kaushik, and he says that, or he or she says that increased awareness helps in getting many doctors to take notice and follow sepsis detection and treatment. He or she would like to know if knowledge exchange from countries who have sepsis control will help, especially for resource-limited countries.
Yes, sure. It's clear. It will be helpful for everybody.
Okay, and I may add a question as well, if you don't mind. So you said that you'd managed that 10% of all of Turkish doctors had attended your education events. So what are the challenges with educating healthcare professionals, be it doctors or nurses, is they are what we call itinerant population. They move jobs, they move hospitals, they move countries. What plans do you have to maintain the education and continue to roll out to avoid a dip in the knowledge?
Okay, we are planning a lot, but these are our society's plans. We should do more collaboration, especially with health ministry. Initially, this education should find place at the faculties, also other healthcare schools, and also for the graduated doctors or other healthcare personnel. We need additional educational campaigns. For these campaigns, already healthcare ministry supporting us, but for the educational change for the faculties, for the other healthcare schools, even in high schools, need to support other ministries, other organizations, and etc. As Turkish Society of Intensive Care, we are already in contact with these bureaucrats. We will see what will happen.
Okay, that's great. Well, I'd like to thank you, Dr. Unal, for an excellent presentation of the work that's happening across Turkey. And without further ado, I'd like to move on to tell you about our next speaker. Our next speaker is Dr. Antonio Artigas, who's going to be sharing lessons to be learned from the success to reduce sepsis deaths in Spain. Dr. Artigas is an Emeritus Director and Senior Consultant of Critical Care at the Sabadell Hospital in Spain. He's a Director of Applied Physiology at the Parc Taulí University Institute and the Autonomous University of Barcelona. He has numerous other chairman roles, and he's a Director of the Acute Respiratory Failure and Sepsis Research Programme. His main research interests are in acute translational research on the pathophysiological mechanisms and treatment of acute lung injury and sepsis. So I'd like to hand over to you, Dr. Artigas.
Thank you very much for your presentation, and hello to all the participants in this fantastic first World Sepsis Congress. And in the next few minutes, I will try to summarize you our experience to try to reduce this sepsis death in Spain. Even in the fields where the evidence-based medicine is mature, like coronary care syndrome, patients do not receive routinely effective treatment. And the major reason is because there are acknowledged barriers or attitude barriers or behavioral barriers that I will review later on with you. It's important to improve the quality of care in sepsis because sepsis is a significant problem related with a high mortality rate, and there is an increase in incidence every year and also an increase in severity. And it's a disease that is related with a high cost in the healthcare system. The potential barriers for improvement and to implement the different guidelines and recommendations of sepsis treatment in the hospital are mainly professionals because there are different expertise in the different physicians that are taking care of these patients. There are difficulties providing education, and there are mainly staff resistance to the changes. And also there is in some areas lack of familiarity with the equipment. There are also institutional barriers as the difficulties of the interdepartmental communication, the barriers in the department collaboration, and mainly is classic the silo mentality between the emergency department, ICU, and the wards. And sometimes also one of the barriers is the limited of staff, mainly of nurses staff, to take care of these patients. Also, there are some physical barriers as the space constraint in the emergency department, or the lack of ICU beds that difficult to admit quickly severe sepsis, or the lack of equipment. Early severity assessment and the time of intervention is a key point. The most important to improve the outcome of septic patients is to have an early identification and to implement an early treatment. It's very important and key to have an early identification of the infection and to have an early control of the source of infection. The antimicrobial therapy also is, as it was mentioned by the previous speakers this morning, is a very important point to improve the outcome. There are some emergency tools, are the biomarkers or the scoring system, or the non-invasive tissue oxygenation, or the rapid infection identification and control that facilitates us the stratification of the patients and to adapt as better as possible the treatment. Our experience participating in the Surviving Sepsis campaign demonstrated that a progressive improvement of the performance of the compliance of the Surviving Sepsis campaign recommendations, and this improvement was followed by a simultaneous decrease in mortality. So there is a close relationship between the improvement of care and the improvement of survival. When we analyze the different studies that has been published using the meta-analysis technique, it's clear that the major benefit is when you apply or you treat early these patients. Patients that are treated late, there is no benefit at all. So the early identification of this patient is a key point if we want to improve the survival in these patients. We implement an educational program in emergency room, in the ICU, and in the wards in many hospitals in Spain, and we were able to demonstrate that the impact of the educational program improving, decreasing the mortality rate. So the mortality rate after implementation of the educational program decreased the mortality rate and the hospital mortality rate too, with a relative reduction of 10% of the mortality and an absolute reduction of 4.3%. The most important experience, according to this study, was the analysis of the impact of the different recommendations in the outcome of patients with sepsis. And we found that there are only some few recommendations that are really playing a key role. The first is the adequate early antibiotic therapy during the first hour. The second recommendation is to keep the patients with lung protective mechanical ventilation, and also to improve the tissue oxygenation during the initial resuscitation. So that means that these are the key points that we need to emphasize if we want to improve the outcome, and probably the treatment bundle and other recommendations are not so important as I mentioned to you. This is an example from a study from Kumar, but we have exactly the same results in the surveillance sepsis campaign. The later implementation of an adequate antibiotic therapy, the higher is the mortality. Mortality risk is 7.6% per hour of delay to initiate the adequate antibiotic therapy. So what we can do to improve sepsis care, and to implement this in our hospitals, I think first it's necessary to have a strong leadership and to create a multidisciplinary sepsis team in each hospital, to involve the stakeholders and the administration of your hospitals. And it is important to identify where to start the initial care in these patients, and also to define the right population of caregivers that should be instructed, and also to teach and to identify the bundled cares that should be implemented, to have a checklist to control the quality of care in these patients, to establish an educational program that is persistent every year, and to maintain this process of improvement is necessary to incentivize the physicians and nurses to have a measurement of the performance and to give feedback to the team. We were able to convince our health department in our country to develop and to implement a sepsis code in our country, and where the different medical specialties were participating in this process, a process that defined a network across all the country with three different levels of care, and defining what the centers that are the sepsis referral centers. This was based in a very simple way to identify the patients according to an A, B, C, D, and E system, very close to the USOFA that was recently published. And doing this, we were able to decrease progressively every year the mortality, the hospital mortality in all patients, in ICU and non-ICU patients in our country. So my last message is important, as a previous speaker pointed out, that if we want to improve the outcome of septic patients, it's necessary to work together, different departments and different medical specialties with the same objective to improve the survival in septic patients. Thank you very much. And I will be very pleased to answer any question.
Okay, thank you, Artigas, for an excellent presentation of your learning from Spain. I really enjoyed your systems thinking approach and your knowledge of the potential barriers. We have a question here asking you to elaborate on the education program that you implemented at your hospital, especially the nurse education. Are you able to do that for us?
Yeah, the problem with the educational program is to assure the continuity and to have a continuous self-evaluation in the professionals that are participating in to the care of these patients. The study that we published in JAMA was a program that was face-to-face. But now we are implementing and developing in simulation programs where every physician and nurse can be connected, and then to have a self-assessment, and just to keep update all the professionals on the education to improve the care of these patients. So the continuity is very important.
Yeah, it was great to see actually that your education program actually contributes to a reduction in mortality. So that's really, really good work. One quick final question from me. You mentioned that you incentivize the physicians. How do you incentivize physicians other than it's the correct thing to do for your patients?
You mean how we incentivize the professionals? I think there are two ways that is we are doing is to give feedback to the professionals, because to say data is our resource, so you need to have to recruit and to record all the information and to give a report to all the septic multidisciplinary team to see the good results or bad results, but good results, and then and also to take in consideration the improvement of care and improvement of quality of care as an objective for the general improvement care in the hospital.
Okay, that's great. Thank you for an excellent presentation and for answering our questions. I'm conscious of time, so I think we will move on to our next speaker, Dr. Marty Doerfler, who I've heard speak several times before. He leads the Office of Clinical Transformation in the Centre for Learning and Innovation and is responsible for guiding the adoption of evidence-based clinical practice and helping to define and facilitate clinical improvement efforts across Northwell Health, which was previously known as North Shore Long Island Jewish Hospitals, if I'm not wrong. He's a board-certified internist, and he's a nationally recognised clinical leader in critical care medicine and improvement science. So, Marty, over to you.
Yes, thank you. And that was an excellent presentation by Dr. Artigas. That what I'm going to talk about here, I think, will flow fairly nicely from in doing a little deeper dive into the processes and history of a fairly large American health system and how we've, to date at least, had significant impact on sepsis mortality within the health system. For those not familiar with us, this is what we look like. This is the greater New York metropolitan area. We have 10 acute care hospitals, 5 community hospitals, a number of affiliated hospitals, 3,000 employed physicians, 19,000 physicians credentialed within the health system, 61,000 employees. And we cover an area that is populated by greater than 10 million people. I don't know what the exact numbers are in our area, but we're a pretty big place. What I'm going to talk about here, the next couple of slides are actually going to just be some text slides like this, that I'm going to walk through the history of our initiative and then go into a little bit more depth and show you some of what we've done. But this project began in 2008, was established as a health system priority by our CEO, Michael Dowling, and I will put forward that that is a very critical component of success, as Dr. Artigas had shown on his slide. Having leadership engaged in this is something that is very, very important. This is not just frontline, but it's also not just leadership. We began in 2009 by forming a task force. They created recommendations and an initial algorithm for how care should occur. And then we began the process of collecting data, review, and analysis. And this is something that I want to draw attention to because this is actually a very, very important step. you cannot act on data that is not of high quality, and data that you obtain just through normal processes isn't necessarily of high quality. Our first data was largely uninterpretable, and our first process improvement efforts were really around how to get data from the front line and the actual care processes that was accurate. And we spent a fair amount of time on that. We began a partnership with the Institute for Healthcare Improvement. I think most people are aware of IHI. That began in, I have on here 2012, I think it was 2011 that we actually began that initiative, and focused on a system-wide collaborative to improve the care of patients with severe sepsis. And I'm being specific here because over time we broadened out to be all sepsis. And we also began initially focused on just one environment, our emergency departments. And again, we broadened that out afterwards. But part of our process, and I would argue to others, is to start small and grow. All the sepsis teams in every facility were trained in improvement sciences and the Plan, Do, Study, Act methodology. As part of the IHI process that they brought to us, we have 3 learning sessions per year where all of the sepsis teams from all the hospitals go off-site for a day. Originally it was 2 days. We've narrowed it to 1, and they learn the science of care, of sepsis, but also improvement science simultaneously so they can go back to their day jobs and be working on actually making things better by changing what they do. And then they go back and engage in that. We focused on building our bundle. We did not focus on let's get perfect care on everybody, but we began to disassemble the 3-hour bundle. And as Dr. Artigas showed in his slides very nicely, we decided at that time that the evidence best supported the most important thing to achieve in achieving improvement in sepsis mortality was highly reliable early antibiotics on individuals that we recognized. And so that was the first piece of this that we worked on. We worked on lactate turnaround time as another component of that. If we don't know they're sick, we don't know how aggressively to treat them, and then built from there. In 2014, we expanded out our efforts to the medical surgical wards in the hospital. Quite honestly, we've still not focused on the intensive care units. If you want to get this early, you focus upstream, and the intensive care units are where people end up at when you don't do a great job prior to that. And we, in our system at least, felt that they were doing a pretty good job to start. And then lastly, we started putting on empiric fluids in 2014, 15, and even this year. So we've built our bundle progressively to get highly reliable on the different elements as we moved along. Dr. Artigas talked about incentivizing physicians. We incentivize the entire senior administrative team. In 2014, the achievement of antibiotics within 180 minutes for patients with severe sepsis went on the system quality scorecard. And that is a component of how people's bonuses are determined, and not just the doctors, but the finance people and the head of the hospital and the rest. So all of that are part of what we did in our initiative. Lessons learned. Some of this Dr. Artigas talked on, but I'll rehash it because you can't hear this stuff too many times. You need a structure for leadership, partnering, communication, and reporting. You need to overcome barriers, and data definition and confusing is a very important one. We redefined time zero based upon what the clinicians felt it was reasonable to hold them accountable for. Those of you from the U.S. know that the Center for Medicare Services is saying you need to follow certain things. It's perfectly reasonable, but data for improvement, metrics for improvement are not necessarily the same as metrics to hold accountability, and we were working on improvement at that time. Define your outcomes and what you want to achieve, develop processes to achieve them, and that's a key component to this. Assess how to perform what you think you need to do, standardize processes to increase reliability, utilize process to facilitate change, and then the greatest gains realized when we refocused on early identification, aggressive fluid resuscitation, and timely antibiotics. So the whole 6-12-point bundle piece, we really focus on 4 elements and nothing but at this point in time. We haven't gotten highly reliable on everything there. Some further lessons learned. We treat sepsis, severe sepsis, and shock differently. They have different components to it, and the processes that are involved are different, and venue-specific expertise. The critical care people initially were telling our emergency physicians how they needed to care for people in the emergency department. Quite honestly, I'm a critical care physician. I don't know how patients need to be treated in the emergency department and vice versa. So you need to have the actual frontline people here. And then data transforms the culture. Once you have results that are showing you're moving in the right direction, then things begin to change. Now on this slide, and this is a detailed slide showing multiple years of the continuous step down, we went from a mortality rate of about 31, 32% to most recently the control chart mortality rates are 13%. So a major reduction in mortality. And I could go over each one of these. The first piece of this was guidelines and education. The second phase of this was focusing just on the emergency department. The third phase of this was really pushing the emergency department to become reliable on antibiotics. The next phase is engaging the floors, and the last phase is when we start pushing on fluids. So every component of this work drove us farther along in our mission. These next couple of slides I'm only going to show for future reference so you have them to come back to because we don't have time to go through them. But on this slide is our emergency department algorithm, and you can't see this very clearly unless you have it on full screen. But again, you can come back to these slides, and they begin with the triage process, and you move down a sepsis pathway, or if they triage with certain criteria, you move into probable severe sepsis while you're waiting for labs. We didn't wait for things to get moving. A slightly different version of that for the inpatient, and again, you can look at all of this in more detail. I'm leaving them up just enough time for them to be frozen for if this is on YouTube or whatever, but you can certainly get the slides from the sessions if we're going to provide them, as I assume we are. The first slide in a little more detail so you can actually see this. You start off and based upon triage criteria, move down a pathway of beginning with sepsis, or we just presume based upon how sick you are and you have an infection, you have severe sepsis. Farther down, there are pathways to cross over and giving you details on our definition of organ dysfunction and what our actual bundle elements are on these other components of it. Then I want to actually spend a few minutes here in closing this out with the time allotted with a little bit of how this actually works. So a case study, one of the hospitals is working on things, they're not really sure how to make things better. But you really go in and map things out. Every single step involved in a component of the care process. What it takes to give antibiotics to a patient, what it takes to get bloods to the lab and the results back to you. And this is what's called a swim lane process map. So all of the individuals that are involved are on a lane and the process flows back and forth and you can see exactly who's supposed to do what in what order. And then you move to the next step of sitting down and identifying in a group setting with everyone represented, from the unit clerk to the nurses to the doctors to the respiratory therapist, where are the steps that we think that there's something that could be fixed? And then you move to the next step and you say, which of these are the most important and are going to have the biggest impact on what we're trying to achieve? And then you begin the process of doing your plan, do, study, act work around one problem. If you look over the 7-8 years of us doing this work at Northwell, there have been thousands, if not tens of thousands, of plan, do, study, act activities gone on in the various hospitals on the various steps of this to really take out variability that is not helping in the care of patients and is taking time and wasting time when we know from all of the data that's out there that you need to recognize as soon as possible, you need to get your tests off as soon as possible so that you continue your recognition of severity, you need to get your antibiotics as soon as possible, you need to get your fluids going as soon as possible, all of that as major components of making a difference in the care of your individuals with sepsis. And I know I've talked fast in the interest of getting all of this in because there's an enormous amount here. It's hard to summarize 7-8 years in 12 minutes, but hopefully I've done that in a way that is useful to the audience, and I look forward to any questions.
Thank you, Martin, for a great presentation. I've heard you before, and every time I learn something new. I love the improvement science approach that you take at Northwell, and the quality planning is an important part, even before the plan, do, study, act cycle. You talked about the importance of measurement, and you talked about knowing that you want to concentrate on 4 big pieces of work. With regard to your measurement and your process measures and your outcome measures, you talked about, what about balancing measures? Did you look at any unintended consequences? And if so, what were they?
We look at unintended consequences. Yes, one of the things, and I'm sure that this is familiar to many in the audience, one of the things that people really focused on here was the adverse consequences of the early aggressive empiric fluid administration. And so we have looked at that, and what we've found is pretty much the same thing that Terry Clemmer and the group out at Intermountain published a couple of years ago. As we became more reliable in administering our aggressive fluids, we actually reduced the incidence of mechanical ventilation in our population. So we came to the conclusion that we were not risking harming patients by being aggressive with fluids. We were risking harming them by not being aggressive with fluids. Similarly, we looked at the concerns around antibiotic stewardship, and we engaged our infectious disease colleagues in this, and they felt that we should indeed be aggressive in the early use of broad-spectrum antibiotics, but that they promoted a timeout at 72 hours to look carefully and see what your data is, how the patient has progressed, and if anything at all supports narrowing or even stopping antibiotics to see whether you should continue them. So I think both of those are probably the key elements that people are concerned about, and we've looked at both of them and concluded, for the time being at least, we continue to monitor them, that the course we're on is the best one for the care of our patients.
Okay, that's great. There's a question here from Conrad, and I know the answer, but I'll let you answer it. Will you or have you published this work?
Yes, so we've published first the methodology that we used. We were awarded the Eisenberg Quality Award last year, and so the Joint Commission Journal on Quality and Patient Safety has our methodology and a detailed analysis of our outcomes, including financial and accounting measures, has just been accepted for publication by Critical Care Medicine, so that will be coming out sometime in the next couple of months, and we've published in the Annals of Emergency Medicine an analysis of the fluid metric that we have been using, which is starting our fluid boluses within 30 minutes of recognition of severe sepsis, and that is an independent predictor of patient benefit. That is already in press in the Annals of Emergency Medicine. So we've been analyzing our data. These are all qualitative analysis because none of this is randomized. But if I go back to the slide on the outcomes, every one of those dots is 1,000 individuals. In the size of our health system, we see on average 1,000 cases of sepsis, severe sepsis shock per month. So our data set on this is quite large and allows us to do the kind of analysis that we're talking about.
Okay. And one final question. Have you looked about the return on investment with regard to this work compared to lives saved?
So, life saved or financial? Give me what you want on your question.
Well, so if you look at you've educated a lot of staff and you take them out from work, so that's going to be a cost to the organisation. So there'll be the cost to the organisation, but then do you recoup that cost back by less deaths, less time in ICU, less ventilated days?
Yeah, so it's actually the cost of this is, or the realized cost of this has been fairly low. We have a relatively small team dedicated to this as their day jobs. Most of this is done on the margins of people who are caring for patients every day and what they fit into the time between things in their administration. So the overall quantifiable cost is low. Again, we've reduced mortality rate from 31 to 13%. Turning that into actual number of saved lives would be a large number, but it's hard to take a mortality rate and turn it into a hard number, so I hesitate to do that. On a financial basis, we've actually seen significant benefits. One, by having earlier and better recognition in the U.S. at least, where better documentation translates into more accurate coding. There's been an uplift in our revenue in the early on phase of it. And the analysis that we're publishing in Critical Care Medicine actually shows that when we provide perfect care, all four bundle elements as we've defined them are done compared to less than perfect care. There's actually a reduction in cost to the greater community. What we get paid, what our revenue is, falls. But what we save in reducing costs by ICU utilization, time on mechanical ventilation, antibiotic usage, et cetera, is even greater, to the point that there is a net benefit to margin in the health system budget by doing this care very well. And again, that will be published in the Critical Care Medicine at some point in the near future. And I urge everybody to look at that in detail, because I do think that it's enlightening that you can provide better care and save money for the broader community and do better financially in your own institution.
Okay, that's great. That's great, Martin. That's fantastic. We could listen to you all night, but I think we're going to have to move on for the sake of time to our next speaker, who I'm sure will be equally good, and that is Dr. Eric Williams from the United States as well. Dr. Williams pursued his medical education at Duke University, and he subsequently trained in pediatric critical care medicine. He joined the Baylor faculty in 2004 and worked in both the pediatric and the cardiovascular ICU, and he became the medical director of PICU in 2008 and then the medical director for quality in 2010. And he's now the chief quality officer at Texas Children's Hospital since 2014. He's got an interest in integrating systems and resilience engineering, so I'm looking forward to hearing what he thinks about reliability in sepsis care. Over to you, Dr. Williams.
Hello, and thank you. This is actually turning out to be a wonderful, wonderful conference, and I feel that everyone's involvement just sort of accentuates all the other work that we've done. And hopefully the work that I'm going to speak towards will also echo with a lot of the work that's been already done. And so my talk today is to describe the potential of rapid response teams to benefit sepsis and sepsis outcomes. And I think the biggest thing is that it's the potential, which, it's such an exciting time to be a part of this, to watch the impact of performance improvement science when it's done well, as Dr. Doerfler has shown. And so whether you define your team as a medical emergency team or a rapid response team, and wherever that team is necessarily employed within your hospital or deployed, the important thing is it's this complex socio-technical system, and that involves the whole human factors engineering piece. And so that's the part that I like to focus on. So if you actually look at some of the different organizations that have looked at the details and how technical work is actually done in healthcare, it's very, very complex, and we sort of have a rudimentary understanding of what's actually going on. And the realization that the system we work in often adapts because people manage to work around the complexities that are inherent within that system. And importantly, the technical work, in terms of our success in what we do, is clearly dependent upon the knowledge of illness and the response. So all of our things with respect to education around sepsis and those elements are hugely important, but the delivery of that is the ultimate achievement for success. So how to get things done, where things are supposed to happen, what's likely to happen, and how to make what is needed happen. I think sometimes that's not necessarily focused on enough in terms of getting a solution that will actually solve any type of problems. And more importantly, people on a day-to-day basis create success in these environments by managing these so-called messy details. And I think when we wrap our arms around sepsis, we would all say that sepsis is messy, and it's not so clear-cut all of the time. And people, as the data changes in front of them, as information guides them, they adapt their performance. And importantly, that becomes the nature of everyday work, but oftentimes we don't necessarily measure any of that. So importantly, getting to that piece will be an important thing in the future. The messy details of if labs are late or information is incomplete, you have to make assumptions at a certain point in time. So when I think from an engineering standpoint of what is the problem that this entire Congress is trying to get at, and if I had to define it, we need a way to minimize the time from evidence for concern related to sepsis, obviously, to a definitive treatment. That's our goal in this. And it's problematic, right? So the first part is that accurately identify. And I think Dr. Doerfler pointed to it too. It's like, well, is it sepsis? Is it probable sepsis? Do I know with 100% certainty? So the people who are accurately identifying these things with, okay, I'm looking at procalcitonin, different biomarkers, or different types of pathogen detection. But the key piece is this, how to subsequently direct the definitive treatment. And that's the different teams of people do that. Systems can alert us to problems, but it's the teams of people working together that have to do that. So our goal, everyone's goal together, is defining these optimal triggers, and many people have started talking about that in the last 48 hours, and then refining that highly reliable care team. And I think that's all what we endeavor to sort of move towards. And we know that it works, right? trauma teams around the country, especially in pediatric trauma, coronary emergencies. If I have crushing substernal chest pain right into my left axilla and jaw, I don't want to have there be a delay if someone's considering maybe it's abdominal upset or indigestion. The system needs to respond effectively. And similarly with stroke, if I'm having a certain type of weakness. So we know those things work, but those are much more easier to define. So in pediatrics, our classic approach is to use the ACCM-PALS evidence-based guidelines. And not to belabor and go through the details of this, but all the clinicians that you ask could recite the details of what's contained within this document, but does it actually get implemented in a timely fashion? And I think that's the key piece for performance improvement and quality improvement. So it means, can you recognize the problem? That's the trigger piece, and the do something part. So that's the combined goal with the work. So in our emergency department, when we deploy this emergency team, you know, you have to go through the arrival to the emergency department, the triage process, you know, a bunch of stuff happens, and then you dispose of the patient ultimately to their particular care area. In choosing that time zero, again, referring back to Dr. Doerfler, that picking that right time is easier in the emergency care setting. But the approach is to recognize badness, do something, and then standardize or protocolize your work to minimize and pull this time together. So the earlier we can intervene in things, we can have improvements. Our work with respect to this resulted in significant process improvement times in the timeliness of antibiotic delivery and time to the first fluid bolus. And although we didn't go into it with mortality, looking at a mortality benefit, we ultimately had an impact in mortality, as well as the reduction in patients who subsequently went on to need CRRT therapy for renal dysfunction. So this slide identifies the problem. The uncertainty is on the y-axis there, and the further I am out from the diagnosis, it's less certain. And so as my nonspecific symptoms become more specific, we can hone in on the diagnosis. As new tests become available, then we can get clearly more towards where we need to go. So it turns out when we actually looked at our rather broad encompassing pediatric septic shock alert, the sensitivity 81%, specificity 89%, but the positive predictive value was only 4% because it was so broad. So as you can imagine, the people's response was alert fatigue. You're alerting on many, many times, but the goal was to try and capture everyone at risk. So you're further out on that uncertainty curve. Similar people have looked at if you could actually predict a cardiac arrest. So a high-risk trigger, they could understand 24 hours prior to cardiac arrest just by looking at different vital sign measurements, and ultimately an intermediate risk category 44 hours prior to the arrest. And ultimately, they thought that the earlier clinical assessment could result in significantly improved outcomes. But the difficulty for this new trigger is, what should I do with that intervention at 24 hours ahead of time or 44 hours ahead of time? So as the new triggers come along, the highly reliable team has to determine what are they going to do with that information. And in similar work, a group looked at just potentially catastrophic outcomes with respect to ICU care, and they found that they could prevent future deteriorations at the bedside, and using a more dynamic score could actually capture patients well beyond what a typical TACHI or a PRISM-3 score would find for them. So I go back to this classic approach to monitoring a patient, and we see vital signs, heart rate, blood pressure, saturations, and blood pressure in a particular patient. And we have that art of medicine where we combine all this information into a particular package and we kind of do stuff with it at the bedside. And how can we mathematically manipulate that? So this is actually data that an individual at our institution did with respect to the hypoplastic left heart syndrome and the prediction of either cardiac arrest or need for intubation, which they published. The basis being it's difficult to recognize changes from standard bedside monitoring, but you can use mathematical transformations so that, I hate to use the power of big data or the statement of big data, but these could actually be done. So I show you this figure to show on the top part, the heart rate in black, the saturation in green. It's a hypoplastic left heart patient, and then the respiratory rate in blue. And strikingly noticeable is a lack of significant variability there. It looks quite healthy, so to speak. But the red score on the bottom actually happens to be a particular risk index mathematically derived from all of the features of the vital signs. And so interestingly enough, as you march across the bottom there, you'll find out 1.5 hours before the event, there's a 3.87 times likely to arrest than the average patient. In an hour before, it goes up to 10. almost 20 times likely to have a catastrophic event for these patients, and similarly in a short, 15 minutes more, 35 times more likely. The important thing for us is being able to capture this data and then being able to decide, what am I going to do with these particular interventions? So this will happen for us with respect to sepsis as we're able to incorporate more information regarding the patient's pathophysiology. Similar work looked at how can we actually deliver that type of care at the bedside, wherever that bedside is, and ultimately found that the rapid recognition and administration of therapies can be done outside of critical care. And similarly, they decided to change the term to that critical care was actually a need and not just a place that you could be clearly doing these therapies in other geographies, but the success ultimately required champions, an appropriate infrastructure, again, as many people have elucidated to, with well as education and appropriate implementation. Again, in terms of improving the early recognition and response to in-hospital sepsis, everyone has talked about an educational framework, have an understanding of what the expected response to treatment, and ultimately minimizing unnecessary variation. But I can't emphasize that enough, that in certain cases, we absolutely need certain variation that allows us to succeed and ultimately provide those clinical indicators for quality improvement initiatives. The data, again, and it's been said again, the data drives where your quality improvement measurements need to go. So my last feature, and again, I've rapid cycled here for you. While you're waiting or determining the next best trigger, create the dedicated team to apply the highly reliable resuscitation paradigm so that we can consistently and appropriately care for these patients. Machine learning is going to help us so much in the future. So I'd like to close on that and be happy to answer any questions.
Okay, thank you, Dr. Williams, for an excellent presentation about how we can, vital signs will teach us things in the future through automation. So one of the concerns people have is with the adoption of rapid response teams is you may end up de-skilling the ward staff. So if critical care come and do everything and take patients away, that actually the ward staff are less and less able to do things. What are your thoughts on that?
It's definitely a risk. I mean, as soon as you have a dedicated unit, for example, as soon as you put all of your cardiac patients in a cardiac unit, the general pediatric intensive care unit now no longer learns those skills. So we actually did surveys back to the teams involved, the bedside care providers involved in the rapid response on the receiving end. And their feedback was they wanted to know more information about why the transfer occurred and what other educational things they could receive. And so based on that, we actually developed an educational paradigm to go back to them and share with them, well, this is exactly the things we were concerned about, and or maybe you should have been concerned about an hour earlier or an hour and a half earlier. That gets back to the difficulty in defining the time zero. It's much easier sometimes in hindsight than in foresight. But actually asking them what they needed to learn and try and bring that back to them. But I think ultimately our success is going to depend on these expert teams. But you're right, it will dumb things down for people. But we're going to have to somehow manage health information technology to bridge that gap so that it can be smarter to alert us, again, sort of the topology of alarms that are going off to help guide us. And like with that particular hypoplastic left heart syndrome patient, long before the patient's ill, it's capable of telling us something.
So one of the things we're seeing in Scotland and elsewhere in the UK is using admission to critical care as a learning event. And every time someone's admitted to ICU, there's a review, but not just of bad practice and missed opportunities, but obviously of good practice as well, and feeding this back out to the referring teams. Are with your rapid response teams, do you feed back the good practice as well as the bad practice?
Are you referring to the learning from excellence that's come out of Scotland, or?
Well, lots of just, it's not just learning from excellence, but just if I admit someone to ICU, we normally only give feedback to teams when they haven't done well. But what we're actually we're actually going to feed back to the team, so you know what, you did your vital signs, you followed your algorithm, you resuscitated the patient, you referred them appropriately, and you escalated care, rather than you missed this, you missed that, and actually use kind of positive reinforcement as much as negative.
You're absolutely right, because sometimes a patient admitted from the emergency center to the ward who then has a rapid response in 12 or 18 hours, there's usually a lashback of like, how did the emergency center think that that was appropriate? Who screwed up to put that patient in the wrong place? Whereas we've looked at it, this was the appropriate, the system worked, the rapid response team worked, and to giving kudos back to those people like, thank you for calling a rapid response. Thank you for being engaged in this. Thank you for raising your hand and saying you have a concern. That's a big culture shift for us, absolutely.
Okay. That's great. We've got some more questions, but I'm conscious of time, and maybe if you're able to hang around to the end, we can pull together some more questions. So thank you, Dr. Williams, for an excellent presentation about your work. And I'm next going to move on to Dr. Diaz, who I first met with the WHO back in 2010. Janet is an accomplished specialist in intensive care medicine with expertise in clinical medicine and global health. She's committed to working with medical and public health professionals to deliver quality, safe and cost-efficient care to critically ill patients in resource-limited regions. And since 2010, she's worked for the WHO Epidemic Clinical Management Team as a technical lead for Severe Acute Respiratory Infection Critical Care Training Project. And she also works in San Francisco at the California Pacific Medical Center, which is a tertiary referral center. Over to you now.
Hello, good evening. I want to thank you, Kevin. It's good to hear from you again, and the organizers, Conrad, and everyone for this wonderful opportunity. My only disclosure is that I am speaking about my experiences and reflections after working for the WHO for the past 5 years on the SARI Critical Care Training Project. We're all trying to answer the same question: how do we save lives from sepsis? And many of us are working in resource-limited settings, where the mortality, as we've heard, and the burden of disease is high, as are the challenges. The challenges, to briefly go over, are structural challenges such as access to medicines or oxygen therapy, perhaps in this case. Human resource challenges such as not having the right skilled healthcare workers manage these patients. Organizational challenges, not just in the ICU, and we know there's great variability in what an ICU looks like around the world, but also at the hospital level, and more importantly, at the healthcare system level. And finally, the challenges of implementation, specifically, how do you make healthcare workers change behaviors in order to improve processes of care? We all know that one size will not fit all, although we may try. And that there will be more than one approach to address the complex situation of improving care for patients with sepsis. Thus, I want to take this opportunity to acknowledge so many of our colleagues around the world that are also working on sepsis-related interventions to improve care in resource-limited settings. And I do believe that innovation is important to make this field move forward and reach more people on the ground. Our hypothesis is simple. We work to empower frontline healthcare workers that are caring for SARI patients in an ICU with the knowledge and tools to improve clinical management. At the same time, we work to support the Ministry of Health of our member countries to achieve their goals. And what are their goals? Of early detection of SARI patients, of prevention of spread of infection, and early treatment. And when we talk about SARI specifically, this training project was developed after the pandemic in 2009. So it is dealing with influenza, seasonal or pandemic, avian influenza such as H5N1 or H7N9, MERS coronavirus, and the potential future respiratory virus of potential international concern. And together, we hope that this will reduce deaths from SARI and sepsis. Essential to our work are many aspects of our implementation. Flexibility and adaptability is essential because we work on the request of health ministries, our member countries. And all countries have their own political systems, economic situations, educational systems, own healthcare systems that make this quite complex. Commitment and persistence is necessary because we're working to support local teams make sustainable changes and improvements in clinical management. And as we all know, there is no simple solution or to this, and this takes time. Strategic planning and patience is also necessary to keep on track towards the vision and goal. And opportunism. This means that when we see challenges, which there are many, that we don't see them as negative, rather we see them as opportunities to make a change, an opportunity for improvement. Our course is 3 days, classroom-based course. It has been peer-reviewed by many of you in the audience, I think. Thank you. It has been piloted and road tested now for over 5 years and has trained over 1,000 doctors, mostly doctors, some nurses, in 15 countries. The content is based on WHO guidance when that is available, and I just wanted to acknowledge 2 recent WHO guidelines that are really well done in the pediatric field on oxygen therapy for children and the pediatric emergency triage assessment and treatment guidelines that are very transparent in nature and very resource conscious. When these are not available to make our training materials, we refer to international guidelines such as the Surviving Sepsis campaign, which I look forward to seeing the new iteration in the near future, and ongoing research, and of course, understanding that a lot of the research is coming out of high-income countries, and that, of course, has its weaknesses. So we go to countries at the request of the health ministries, and we tend to meet the needs of the country. Hotspot countries that we have been to include Indonesia, Vietnam, and Egypt, and that is because of the activity of H5N1. We also work as an outbreak response. So if a country is seeing a surge of cases of SARI, then we get deployed as an educational clinical team to provide education alongside epidemiologists or laboratory specialists, depending on what the country is asking for. And we've done those activities in Egypt, China, and Fiji most recently. In addition, we work under the Pandemic Preparedness Framework, and currently that is part of the work we are doing in 5 Central Asian countries, including Tajikistan, Turkmenistan, Uzbekistan, Kyrgyzstan, and Armenia, to prepare the countries better care for SARI cases, even though they had not seen an outbreak in these past few years. Back to the course. Our course is adapted to meet the needs of the training. It is a 3-day course, but we also add on additional days to go see the hospitals, to see the conditions that the clinicians are working under, to see how the ICU is set up, how the admissions unit or the emergency room is set up, what equipment they have, and we add on skill stations or practical sessions based on the needs that the doctors and the Ministry of Health feel is necessary. The adapt actually key, and someone spoke about this, I think, earlier today, that it is important that when we arrive, we see what the local situation is, and we adapt the materials as quickly as possible so that they are practical to the doctors that we are working with. The training materials are currently translated into Russian, Vietnamese, and Mandarin language. The course itself uses an interactive problem-based learning methodology, so it's adult learner-focused. We have a toolkit that is a very handy compilation of algorithms, checklists, scales that can be useful to doctors at the bedside. We provide a test at the beginning and the end and a daily evaluation. And on average, we've seen an improvement of 20% of classrooms, improvement of 20% by the, on average of the classrooms, and very high satisfaction ratings. As you can see, the core agenda is actually quite comprehensive, and we follow the patient from it's their first point of encounter with the healthcare system through the ICU and then to discharge. So there's 5 major themes of the content. One is early recognition, early detection, triage monitoring. The second is early infection prevention and control to prevent the spread of infection to healthcare workers and to other patients. The early diagnosis and early antimicrobial therapy and diagnostics vary depending on the country. And then, of course, early supportive therapies, and this is what we think happens at large in the intensive care unit, so resuscitation strategies, lung protective ventilation, targeted sedation and delirium management, weaning from the ventilator, and the preventative measures that we use in the ICU to keep it most safe. And our 5th layer is on ethics, which we think is important when dealing with potential pandemics or outbreaks. as well as quality improvement, which is an essential skill for making sustained improvements at the local level. I feel the success of our training project is built on the relationships we have. We have an outstanding group of international faculty that dedicate their time to travel and go to all parts of the world to teach this course, and who quickly learn that they're not there just to teach, but they're there to learn. And peer-to-peer knowledge exchange is really the essence of what we're doing. The learners and participants that we've trained have been gracious, open to learning about new ideas, especially in the more remote areas of the world where doctors have not been to an international congress in many years, have not heard about surviving sepsis campaigns, or been up to date on the recent literature that we are more familiar with. But despite their challenges, are open, inquisitive, and wanting to learn. We do this work with health ministries who invite us and are transparent and honest with the struggles that they are facing, and of course our WHO colleagues that are in the country and in the region. We are committed, as I said in the past, to looking at challenges and that the doctors are facing or the health ministries are facing, and help them work together to find opportunities for change. How can we support their work and moving farther along to their vision? So during our first visit, if things go well, which they usually do, then we plan a second tailored training, perhaps in the next year, perhaps the trainer's approach, if there is enough local expertise to do that, and support them in other projects as needed. I want to highlight the work we've done in Central Asia because we decided to support the health ministries there develop national clinical management guidelines for SARI. And this was an opportunity that the health ministry saw to improve and standardize the care of these patients, to use it as a tool to educate healthcare workers, and really to promote an interdisciplinary communication and effort between the various local healthcare professionals that weren't necessarily speaking to each other that often, didn't have the opportunity. So this was the goal also to improve communication between the Ministry of Health and the frontline clinicians. And our hopes is that this will improve opportunities for funding and help health ministries continue to improve resources and strengthen their healthcare systems. So we have ongoing projects in multiple countries, and I do believe our success is also based on the commitment for continuity to help these countries reach what their ultimate goals are, and each country takes its own path. It's been very interesting to be on the journey to improving healthcare worker knowledge on the topic of sepsis and SARI. A note about the WHO is currently undergoing reorganization, and that was mentioned yesterday morning. Currently, we are under the Pandemic and Epidemic Department Clinical Management Team, and the name of that will likely change soon, but we'll keep you updated. And I want to make you aware of the Emerging Diseases Clinical Assessment and Response Network. This is a network of individuals, of NGOs, of academic institutions, of other organizations working together to improve the clinical response to emerging infectious diseases as well as the research coordination. So in conclusion, the SARI Critical Care Training Project is working to improve, to train frontline healthcare workers better care for patients with severe disease or severe acute respiratory infection and sepsis, and acknowledges these healthcare professionals are working under difficult conditions but with extreme dedication. We are working with a tremendous team of people that have contributed to this, international faculty, health ministry officials, WHO staff, and of course the participants. And we do so by a 3-day, which started as a 3-day training course that is evidence-based and peer-reviewed and interactive in nature, and has now grown and is able to respond to outbreaks and do much more. So with this, I just want to say thank you, and a special thanks to Dr. Nikki Shindo, who's our team lead in Geneva, and Dr. Caroline Brown, who's our leader at the regional office, and to all the international faculty that have participated. Thanks.
Okay, thank you, Janet, for an excellent presentation of the work of the WHO with regards to SARI. We have a question from Genevieve Paisley, and she said that in Dr. Catherine Maitland's presentations, the challenges of sepsis management in Africa, she shared the WHO Pocket Book of Hospital Care for Children, but she said it doesn't yet contain a chapter on the management of sepsis in children. Is the WHO planning to develop a third edition with an added chapter on the management of sepsis in children?
So that's an excellent question. This is a very, very important topic, which I've spoken to Kate about and other pediatric intensivists. So currently, what the WHO did publish is the revision of ETAT, which is the Emergency Triage Assessment and Treatment Guideline, and that has addressed fluid resuscitation for children with shock in limited resource settings. And with that, uses the much more conservative fluid resuscitation recommendations for the child with shock. So I would recommend, that was just published a couple of, I don't know, maybe 2 or 3 months ago, and you can find it easily on the internet. So that has not been included into the child's handbook because it's a new publication, but those recommendations now supersede what's in the handbook.
Okay, that's great, thank you. And a question from myself, if that's okay. So when I taught quality improvement throughout the world, I've heard when trying to make people, change, they said, well, that this won't work here, we're different. How have you got over that barrier?
I'm not sure if we have, but the way we're trying to get over the barrier is I think quality improvement as a change is such a novel or kind of approach to some areas of the world, and some areas of the world insist they do such a downward approach, so if the Ministry of Health says to do something, then they will make the change. So I think you have to work at both levels, because with working with the Ministry of Health in countries where the Ministry of Health, when they start to make guidelines or say things need to be done in a certain way, then the doctor may feel a push to make the change. At the same time, I feel empowering the doctor with knowledge, information, and tools, right? Just like, what does quality improvement really mean? Starts to kind of start some sparks to take their own initiative. Okay, that's great. Right, we've got one final presentation, which is going to be a video presentation. So thank you, Janet. That was fantastic. Our last presentation is by Dr. Tom Frieden, who unfortunately cannot be here today. He's a very busy man. He's the director of the Centre for Disease Control and Prevention. And since 2009, Dr. Frieden has intensified the CDC's 24/7 work to protect the health, safety and security of the American people, including leading their agency's response to the recent Ebola epidemic and other emergencies. His CDC programmed under his direction focus on combating antibiotic resistance and preventing foodborne and healthcare-associated infections. And he previously led New York City's program that cut multi-resistant TB by 90% and helped India prevent more than 3 million tuberculosis deaths. So I'm going to pass you over, and we've got a video from Dr. Tom Frieden.
I'm pleased to speak with you today as part of this first World Sepsis Congress. All of us at CDC appreciate the critically important work of the Global Sepsis Alliance. CDC works 24/7 to protect the health, safety, and security of Americans. This month, we released a new report calling for more action on sepsis in the United States. Sepsis is a medical emergency. In the U.S. and in many countries around the world, sepsis is a huge problem, and there's much more we can do to prevent, rapidly identify, and effectively manage sepsis. Sepsis is scary. I know this firsthand. 22 years ago, when our older son was 4 months old, he developed sepsis. When I walked in the door of our apartment, I thought he was dead. and he could easily have died if we hadn't rapidly gotten him diagnosed and treated. But today, far too many people around the world are at risk of dying from sepsis. We can and must do more to prevent these deaths. In CDC's recent assessment, we found that sepsis begins outside of the hospital for nearly 80% of patients. Yet in 7 in 10 patients with sepsis, they had recently interacted with healthcare providers or had chronic diseases which require frequent medical care. Healthcare providers are therefore on the front lines of not only sepsis prevention, but also early recognition. Unfortunately, even though doctors and nurses may be seeing these patients, they may not recognize that the patient is at risk of sepsis. We call on U.S. healthcare providers to prevent infections that could lead to sepsis. Recognize sepsis early. Act fast if sepsis is suspected in a patient, and inform patients and families about preventing infections that could lead to sepsis, and the signs they should watch for to recognize sepsis early. Patients, parents, and families should educate themselves about sepsis and what steps they can take to prevent it. It's important to know how to recognize that an infection is getting worse and when to seek medical care. Talk with a healthcare provider about the management of chronic illnesses and getting vaccinated to prevent infections that lead to sepsis. Practice good hygiene, including hand washing. And if you or your loved one is sick, don't be afraid to ask your healthcare provider, could this be sepsis? CDC takes a comprehensive approach to sepsis prevention and early recognition. We detect, respond, and prevent infectious diseases and promote safe and effective vaccines. We promote better management of chronic illnesses such as diabetes and cancer to prevent these patients from getting infections that could lead to sepsis. Our smoking cessation programs protect people from lung infections that often lead to sepsis. We've reduced rates of some infections that occur in healthcare facilities by half or more, but much more needs to be done. In addition to our sepsis prevention programs, we're expanding early recognition efforts by launching a new sepsis awareness campaign. And we continue to engage healthcare provider organizations, patients, and family members regarding sepsis prevention and early recognition. We're also improving the national tracking of sepsis so we can better know where this problem is most severe and whether or not our efforts are making a difference. The bottom line is, sepsis is a medical emergency. We can protect more people from sepsis by informing patients and their families, treating infections promptly, and acting quickly when sepsis does occur. Thank you to our wonderful partners who are working toward this goal. And thanks again to the Global Sepsis Alliance for supporting this event and all of our efforts to prevent and effectively manage this serious and all too often fatal condition.
So this has been a very informative setting and session even. I hope you've enjoyed a lot of it. Do we still have some of the guest presenters around for questions? Okay. While we're waiting to hear back, but I'd encourage you all to become a supporter of the GSA and the Global Sepsis Alliance, World Sepsis Day, and to sign the World Sepsis Declaration. And follow us on Twitter at World Sepsis Day and on Facebook. I know that Eric is still here, and I've got a question for Eric, if it's okay, and that is, how many hours of early signs of septic shock are there for the pediatric septic patient?
The question that I think you're asking is, the struggle we have is on our general inpatient floor. Vital signs are measured every 4 hours. So at best, if you're sampling a particular system every 4 hours, the likelihood that you're going to catch you're not going to necessarily find that any faster than that. And similarly, when you get an abnormal vital sign, does that fall into the trap of is that a measurement error? And so someone then goes about, I'll repeat it in 30 minutes. And so we've struggled in that domain, whereas obviously in the intensive care unit, data is in real time, and you have access to that, and you can have a higher reliability of predicting it. But if your vital signs are infrequent, then your sampling and your ability to understand that system, of inflammation in that patient is much more difficult, and it's dependent upon that time frame.
Okay, well that's great. And the data you had for rapid diagnosis at the bedside, is that available very easily within the hospital setting?
Yeah, because our initial input, again, we were trying to be very, very broad, and it was just based on initially temperature-corrected heart rate. And then that sort of brought up the best practice alert to suggest, hey, this patient could be in harm's way. And then there was a standardization of, do they have any other high-risk conditions to make you think that there was something else going on? And importantly, the patients the patients we didn't necessarily needed a best practice alert for. So obviously, if someone was, cold and poorly perfused and looked like they had meningococcemia, that wasn't the patient that slipped through the cracks, right? It's that patient 24 hours before or 12 hours before, when maybe the fever was the first sign, the fever and the tachycardia. Again, it being sort of non-specific. So we struggled with the low positive predictive value of our value.
Okay, that's great. A question for Janet is that you mentioned that a few nurses have taken your SARI course. Is there any future prospects for a course specifically designed for nursing staff?
Can you repeat that again, Kevin?
Yeah, so you mentioned that some nurses had taken your course, but the vast majority of them were taken by physicians. Do the WHO plan to create a bespoke course for nurses?
I do think it's in the future planning of the training project. The initial work was done mostly with doctors, although it was kind of whoever the Ministry of Health could have chosen to send some nurses. That's why we've had some nurses go through the training. But yes, in order to expand to nurses would be in the future planning.
Okay, that's great. Unless we've got any other final questions or comments from the panel, I would thank you for your time. Does anyone have any questions or comments?
I think that there are two brief comments. First is that patients that with sepsis coming from the war are those patients that they have a worse prognosis. So the mortality rate in these patients is higher than those that are coming from the emergency room. And this is, I think, it's important to focus on to try to detect as early as possible these patients in the war. And secondly is that those ICUs or hospitals where the performance is lower is those that the impact of educational programs and the improvement of the organization will have a higher impact. Those centers that are the performance are quite good, then it's more difficult to try to improve the results. So message is concentrating those centers that they have a lower performance, and concentrate the efforts and to try to improve the survival in patients coming from the war.
Okay. So in relation to those, one final question, Dr. Artigas, in relation to those two comments, what is the best way to overcome the silo attitude between the different departments? So how can we have the...
Well, I think there are two ways. First is to create a multidisciplinary sepsis team in the hospital. And the second is to try to push and to improve the participation of the different departments. I mean, emergency department, the surgical department, the medical department, the microbiology department, and the infection disease department, and of course the nurses too. I think this is a disease that needs a multidisciplinary approach. And to be successful is to create with a strong leadership a multidisciplinary team that can meet every month and to review all the information that is collected continuously, and also to participate in the training and educational programs.
Okay, that's great. Thank you, Dr. Artigas. I think we've got a final comment from Dr. Williams.
Yeah, I just wanted to echo what the last Dr. Rawl had said. It's the leadership piece in terms of breaking down the silos. It has to be the expectation from the leadership and demanding that the teams work in a multidisciplinary fashion. I mean, everyone recognizes the importance of that, but the leadership has to say, you know, you're going to do this, and there needs to be a commitment behind that. Thank you.
Okay, that's great. Thank you. Well, that leaves us really just to thank you all for joining us on this session. I'd like to thank our sponsors for making the first World Sepsis Congress possible. And last but not least, to thank our speakers, which have given us a very informative session. And we're going to have to close it now to allow everyone to go off to their next session. So have a nice weekend, and it's been a very successful first World Sepsis Congress. Thanks to you. Goodbye.
Okay, thank you.